Here's another table for you. What do you know about these tables? Money! What does that mean? That means you need to make sure you take these tables and get a good understanding. The amount of information that is in this table, if you truly understand your pathology, these tables speak volumes to you. You can use these in pathology, pharmacology, microbiology, so on and so forth. So here, the topic is still acute bacterial meningitis, okay? Strictly bacterial. Tell me about glucose in your cerebrospinal fluid. High or low? Low. Protein content, high or low in the CSF? High. Your WBCs? Well, granted, WBC would be elevated in any type of meningitis. But here, specifically, what kind of WBC would you expect to see in bacterial? Good. Neutrophils. Okay. Now, based on that, what are the parameters that we're looking at here? We have the predisposing factors in terms of age. And then, depending on the age, we'll talk about the most common bacterial pathogen. And then, quickly, we'll take a look at management, commonly, for antimicrobial therapy. Less than 1 month. What are your organisms? Your CAM-positive Streptococcus agalactiae. Agalactiae. Memorize that. E. coli, gram-negative organism. Listeria. At least know those 3 organisms causing acute bacterial meningitis in a child less than 1 month. Antimicrobial therapy, this keeps changing, but for the most part, you have ampicillin being a common denominator, plus cefotaxime, or maybe perhaps aminoglycoside. Now, what's an interesting point that the boards love to ask, and clinically, that you need to make sure that if you're getting questioned by your attending, and you want to make sure that you're well-versed with, let's say, drug interactions. What if this is a young child right now, less than 1 month, huh? Let me bring you some biochemistry. You're gonna like this. What if this young child, newborn, was yellow skin? At this point, you're thinking, it doesn't have to be a pathology, does it? It could be physiologic jaundice. Does that make sense to you? Why am I bringing this up? You'll see in 1 second. Physiologic jaundice means what to you? The enzyme within the liver known as UGT, or your glucuronosyltransferase, isn't working properly, so therefore what's happening? You're not conjugating your bilirubin, or at least should I say the enzymes is not present to effectively conjugate your bilirubin. And so therefore this unconjugated bilirubin, which of course means to you lipid soluble and starts accumulating in your tissue. Tell me, what color is your baby? Yellow. Good. Okay, now what happens? How can you prevent this unconjugated bilirubin from leaving the vasculature and going into the tissue? I'm sorry, what did you say? Good. Albumin. So you have a chaperone in which the protein is attaching to the unconjugated bilirubin. Why am I bringing all this up to you? Because you'll be given a scenario, I guarantee, where maybe sulfonamides in a child. Is that a possibility? Is that something that you might want to consider for giving empirically as treatment and such? What do you know about sulfonamides and its competition with the unconjugated bilirubin, albumin? Oh, does that ring a bell? It better. Because sulfonamides will then compete with unconjugated bilirubin to the binding site in albumin. And what will happen? It will then remove, or should I say displace, the unconjugated bilirubin and therefore worsen the jaundice. But what's even worse, the skin, yellow, granted, okay, maybe cosmetically not the best, but what about this unconjugated bilirubin accumulating in a brain and a child? Give me pathology. Good, kernicterus. So please don't forget, sulfonamides contraindicated in a child for obvious reasons, because you want to avoid kernicterus. You didn't see that coming, did you? But now you know it. Repeat what I just said in case you missed it. Very important. Let's move on. 1 to 23 months, and now we're getting closer to 2 years. What kind of organisms are we looking at here? Still Streptococcus, maybe, perhaps, but this time it's pneumonia. Neisseria is rearing its ugly head here. And you still have Agalactia, and we have a newcomer. And that would be our Haemophilus influenza, not the virus. Keep that in mind, but I want to make sure that you're clear. Step back for 1 second. The Haemophilus influenza will be the virus. I apologize for putting this under bacterial, but I like to put this here so that you have common organisms that cause acute meningitis with age. Here, if you're thinking about this age group, maybe perhaps vancomycin. And we have a little bit later meaning what? The 2 extreme ages of life. Very young, very old. For this row, very young, very old. We have Streptococcus pneumonia and Neisseria species. Once again, vancomycin. Then greater than 50, you should be thinking about Streptococcus pneumonia and maybe perhaps your Listeria monocytogenes. All right, so now we're getting to old once again, vancomycin plus ampicillin. And then you have plus a third generation. So here's a general overview as to what you can expect in terms of common pathogens. And the one that you want to be careful of, please, is that 1 to 23 months with the Haemophilus influenza. But apart from that, all of these are bacterial. Okay.